also our ID team also provides ID consults for the Prinses Maxima Center, and we are a total of 4 infectious disease physicians, and we have 1 fellow who's in training. Yeah, so very briefly about my previous experience. So this picture, you asked me whether I had been to Indonesia before. I have many times. My mother is from Sulawesi, Orang Manado. These are our twins. We went to Bali last year, and they were very happy to see my family in Indonesia. So we also went to Surabaya. I also worked in Surabaya when I was still an intern. So I did my DM Pediatric in Dokter Hospital, Erlangga University. And a bit later on during my specialty training for pediatrics, I did a fellowship in pediatric infectious diseases in the KKH Women's and Children's Hospital in Singapore. This was, I think, 7 years ago. I have been working at the Maxima as a pediatric infectious disease consultant since 2018. Like I said, I will talk to you about febrile neutropenia first. I already saw that you have selected some excellent cases to discuss for later on, so I'm very excited about those and also very curious to hear about your own experience. I will talk about febrile neutropenia in 5 questions. So I've selected 5 relatively important questions that we come across in daily practice, and I will talk about those questions and look into the scientific background a bit. I will take into account the guidelines, especially the one by Lernbecher that you also have seen, and also our local guideline at the Maxima and the national guideline in the Netherlands. So first of all, what are the definitions that we are using? The definition of fever that we're using in the Dutch guideline, and I think a lot of the guidelines have subtle differences, but mostly they will come down to this. If the temperature measured is 38.3 degrees or higher once, or above 38.0 degrees Celsius multiple times, we call it a fever. And for practical implementation, a treatment threshold of 38.5 may be used. I'm sure we'll talk about this later on when we discuss the cases. When we look at neutropenia, the definition of severe neutropenia is below 0.5. So those are the definitions that we will use. And then another definition that I would like to talk to you about is whether or not we can make a distinction between high risk or standard or low risk febrile neutropenia. You may notice that in many of the guidelines, they refer to this distinction. For instance, in the Lernbecher 2023 update, the authors recommend that the recommendations that they gave a couple of years earlier remain unchanged. And those recommendations are to incorporate a validated risk stratification strategy into routine clinical management. They gave this off as a strong recommendation, although it is based on low quality evidence. And they also stated that they are unable to clearly recommend any single prediction rule or distinction. So they say that there is evidence of geographical and temporal variation. So it is very important to implement and also validate a local prediction rule or risk stratification. In the Netherlands, when our working group looked at febrile neutropenia, and they looked at this distinction between high or low risk febrile neutropenia, they found that because there is an absence of a generally accepted risk score for children, and also because there is little data on oral outpatient treatment, the working group decided to not make a distinction between standard risk and high risk neutropenic episodes in children, that is. So this is important to bear in mind, that our local guidelines do not use this distinction. So when we look at the most common causes of bacteria that cause bacteremia in pediatric febrile neutropenia, we roughly see that there is no difference from the distribution of bacteria that we see in adults. So this is a table from a study by Alexander, which is published in JAMA 2018, where they looked at the effect of levofloxacin prophylaxis on prevention of bacteremia and mortality in patients with either acute leukemia or who had had a hematopoietic stem cell transplantation. And this table shows you the bacteria that they found in the bacteremia, and they display the bacteremias for the treatment group, so the group that received levofloxacin, and also the group that was without prophylaxis. And as you can see, the majority of bacteremias is caused by gram-positive bacteria, mostly virulence group Streptococci. There is also, of course, gram-negative bacteria, but it's a smaller part. So roughly, when you look at these bacteria also for adults, they are roughly the same. So this is important to bear in mind. Mostly gram-positives, mostly virulence group Streptococci. And then, of course, the other important question, what would be the most suitable empirical treatment for febrile neutropenia? The backbone of treatment in febrile neutropenia is to cover for Pseudomonas aeruginosa. And when you look back at history, the practice of treating with an anti-pseudomonal beta-lactam actually dates from the 1960s. So during that time, Pseudomonas aeruginosa started to emerge as a common cause of bloodstream infection in immunocompromised patients. And ever since, it was regarded an important bacterium to cover in empirical treatment. And although we have seen a decline in the incidence of Pseudomonas aeruginosa bacteremias, it still remains a very serious cause, and it is associated with a very high mortality rate, ranging from 18 to 61% in neutropenic patients. So very important to cover that. And when we compare anti-pseudomonal beta-lactams to see which are the most efficacious or which have less toxicity, then it is thought that both cefepime, the carbapenems, ceftazidime, and piptazo are comparative, both in efficacy and toxicity. I will come back to that later. So when we look at the recent Lernberger guidelines, like I said before, they make a distinction between high risk and low risk febrile neutropenia. And they state that monotherapy with anti-pseudomonal beta-lactam or a fourth generation cephalosporin or a carbapenem would be most suitable. I think in Indonesia, I'm not sure, we will talk about that later, whether you have cefepime. In the Netherlands, we generally don't have cefepime. So I will come back later to the empiric antibiotics that we use. When to add a second anti-gram-negative agent or glycopeptide. This is only advised for unstable patients, so the ones who are going to the ICU, who still have circulatory problems, or when a resistant infection is suspected, or whether there is a high rate of resistant pathogens. For instance, since last year in the Maxima Center, we've had an influx of patients from the Ukraine, and we know that when compared to the Netherlands, the rate of resistant pathogens in Ukraine is much higher. So whenever one of those patients comes to our hospital and is admitted with febrile neutropenia, and we are not sure what the colonization is, we tend to escalate antibiotics in that patient group. So Lernberger, like I said, makes a distinction, and for the low risk group, they advise to consider initial or step down outpatient management if feasible. And I already saw that you have some nice cases where we will discuss the feasibility of the advice in this guideline. So like I said, they advise to consider oral therapy if the patient is also able to take it, and they designate it as a conditional evidence based on moderate quality evidence. So when we look at when we compare the guidelines to the Dutch guidelines, Lernberger in the end says that there are no differences in empiric therapy failure or days of empiric antibacterial therapy based on the antibiotics that they advise. And they advise that institutions can just choose any anti-pseudomonal beta-lactam or a fourth generation cephalosporin or an anti-pseudomonal carbapenem as their empiric therapy. They also suggest, obviously, to take into account local susceptibility patterns and also costs and availability. And carbapenem should be reserved, if possible, for clinically unstable patients. In the Dutch guideline, which is called the SWAP-ID, it stands for a Working Group of Antibiotic Treatment. A new guideline was published this year. The first choice for febrile neutropenia in children would be either ceftazidime or cefepime, which, like I said, it's hard to come by in the Netherlands, or piperacillin tazobactam. And the second choice would be meropenem. They also state that if the first choice would be ceftazidime, to add an empirical gram-positive coverage agent, for instance, vancomycin or linezolid, whenever an infection of a CVC is clinically apparent. So whenever we see a patient with a CVC in place where there's, for instance, a suspicion of a local infection, or where there's whenever there's a very high suspicion of a line-related infection, for instance, when the fever started after flushing the line, then we would add gram-positive coverage in the form of vancomycin. And additionally, in our local Maxima guideline, we also add vancomycin in case of severe mucositis, or for instance, when a patient has had a high dose of cytarabine, which gives a high risk of bacteremia with virulence group streptococci. In the Netherlands, the resistance rate for penicillins in the virulence group streptococci would be less than 10%. So this means that if we treat them with meropenem, the chance of not covering for the virulence group streptococci would be very low. So we would only add vancomycin on top of meropenem if a patient is circulatorily insufficient and goes to the ICU. Another important question that we tend to struggle with sometimes is the value of surveillance cultures for infections with multi-resistant bacteria. So our national guideline says that we should take that into account. When we look at the evidence, the sensitivity of colonization with multi-drug resistant bacteria for an actual multi-drug resistant bloodstream infection in the hematologic patient population highly differs. So between 45 to 91% of the bloodstream infections by multi-drug resistant bacteria are actually picked up by surveillance cultures. Most of the evidence stems from ESBL enterobacterialis colonization. So when you look into the evidence, you will find that there is a very high negative predictive value. So if you are not colonized with ESBL enterobacterialis, the chances of getting an actual bacteremia with them are low. Two studies have looked into the colonization rate of Pseudomonas aeruginosa, and they showed that colonization with Pseudomonas aeruginosa, independent of resistance, can be predictive for infection. So that's also important to take into account. The ESL4 guidelines say that either colonization or infection by resistant organisms is the most important risk factor for an actual bloodstream infection with those pathogens. But when you look at the advice to adjust treatment based on colonization with specific pathogens, that has not been studied for each specific pathogen. but in the end, the working group decided that colonization with third generation resistant Enterobacterales or Pseudomonas aeruginosa should be taken into account when selecting empirical antimicrobial treatment. Should we also take into account other colonization findings, so to say? The guideline in the Netherlands says that initial empirical treatment that does not include VRE or penicillin-resistant virus streptococci or Candida is advisable. So it's not necessary to take those into account. When you look at the predictive value of VRE colonization, they have some predictive value to for an infection in some of the studies, but because the pathogenicity is so very low, it is not advised to cover this in the empirical antibiotic regimen, except of course if a patient is critically ill or when this is highly suspected. So for instance, we've had a couple of patients from the Ukraine who were colonized with VRE. We also sadly had some spread of VRE in our HSCT ward. If such a patient would go to the ICU because of an infection, or for instance, when they have a severe abdominal infection, we would then consider adding cover for VRE. And we usually do that in the form of, for instance, linezolid. So how about the virulence group, streptococci? The data shows that the relationship between colonization and infection with penicillin-resistant virulent streptococci is scarce, so there are no real evidence-based recommendations to be made. So we would usually, like I said before, if a patient is very ill and is on meropenem but goes to the ICU, we would add vancomycin to cover for any penicillin-resistant virulence streptococci, but we would not necessarily always take that into account in the empirical treatment. And I will talk about Candida a bit later on, but several studies have also looked at colonization with Candida species, and they found that whenever there's colonization on multiple sites, it is a risk factor for candidemia. But because the incidence is relatively low, the working group does not advise to empirically treat for Candida. I will talk about that later on. So one of the most important questions that we have to deal with on a daily basis, and I'm sure you can relate to, is the question of when to stop antibiotics. The Lernberger guideline says that if a patient is clinically well and afebrile for 24 hours with blood cultures negative at 48 hours, and there are signs of bone marrow recovery, antibiotics can be stopped. They recommend this very strongly, although the evidence is of low quality. For the low risk patients, they advise that if they are clinically well and afebrile for 1 day with negative blood cultures, consider stopping antibiotics even if the bone marrow has not recovered yet. In the Netherlands, we are a bit more we have tried to show a bit more courage. I have to say that in clinical practice, this is still quite difficult. So we say that if a patient is afebrile with negative blood cultures and clinically stable, we can stop antibiotics after 48 hours, which is comparable to the Lernberger advice. But we also recommend that if the patient is still in hospital and clinically stable, has negative blood cultures, but the fever persists, then we can consider to stop the antibiotics and go to prophylaxis. And this proves to be, well, still a challenge, but it is something that we try to do, and that also the adult hospital has been doing for quite some years already. So a little bit more risk-taking than the Lernberger guideline. And then the final question regarding febrile neutropenia is, how about antibiotic prophylaxis? I'm sure you all know this CID paper from also the Lernberger people where they discuss the antibacterial prophylaxis administration in this patient group. I have taken some of their most important data on which they base their recommendations. So these are cumulative data from the studies that they took into account, where they have studies looking at fluoroquinolones as prophylaxis versus no prophylaxis. They looked at Bactrim versus no prophylaxis, and they looked at cephalosporins versus no prophylaxis, and they looked at the effects on the reduction of bacteremia, on fever, neutropenic fever specifically, and on mortality and antibiotic resistance. And as you can see, in most of the studies, there is a significant reduction in bacteremia incidence and also in fever. Not all of the studies looked at neutropenic fever, but when you look at infection-related mortality, the results are less outspoken. And also, of course, I think the prophylactic use of antibiotics is associated with an increase in antibiotic resistance. And these data have led the authors to recommend that when they look at the ALL group, to suggest not to use systemic antibacterial prophylaxis routinely for children in induction chemotherapy for the newly diagnosed ALL group. And in the tiny letters, they say this is a weak recommendation based on low quality evidence. And they also acknowledge that there is a paucity of randomized data that can be applied to children. Many of the studies were done in low and middle income countries. But they say, if we recommend to provide universal prophylaxis to this group, then it would probably have a very substantial impact on institutions because ALL is so common. And also because there is such great variability in duration of neutropenia. They say that it is not possible for them to give this recommendation, and they recommend to do studies to further look into subgroups who might need it. So this is a very, I think this was rather a bold statement to make, to just suggest for the entire group to not take prophylaxis. But on the other hand, most countries were already doing that. We're not giving prophylaxis. And then finally, a study that I would like to highlight before I go into our own local experience. So this is a study from St. Jude's from 2017, where they performed a single center observational cohort study in induction ALL patients, where they compared prophylaxis with levofloxacin or other regimens or no prophylaxis, which was all decided at the discretion of the treating clinician. And they looked at primarily at bloodstream infection risk, and they saw that there was a lower risk of bloodstream infections. And in these graphs, you can just, I will not go into every single graph, but I think one of the most interesting ones is this one, graph D, where you see this is like a Kaplan-Meier survival analysis, where they show that if you are on prophylaxis, whether it is levofloxacin or another type of prophylaxis, the risk of bacterial infection is lower compared to the patients who are not on prophylaxis. And very interestingly, I thought this was also translated to a difference in febrile neutropenia, but also very interestingly, they found a difference between the levofloxacin patients and the risk of Clostridium infection, which was lower in the levoflox group, which I still don't fully understand, but I thought it was an interesting finding. So how do we use these data in the Maxima Center? Well, based on the recommendations by the Lemberger group, as of July 2021, ciprofloxacin prophylaxis, which was still given in the induction phase of the ALL treatment, was discontinued. So we stopped giving the prophylaxis 2 years ago. But But then after a couple of months, we started noticing an increase in gram-negative bacteremias, also Staph aureus bacteremia. So what we did was perform a controlled cohort study. So we took 200 patients who were starting on ALL treatment, and we looked at the patients who were on prophylaxis. So those were 106 patients. So these were retrospective data. And we also looked at the patients who started their treatment without prophylaxis because they started it after July 2021. And we found that the risk for bloodstream infection was significantly lower for patients who were on antibiotic prophylaxis. I will show you the survival curve later on. We did not find that this translated to a significant difference in pediatric ICU admission or mortality. And we also didn't find a difference yet in ciprofloxacin resistance rate, which still remained around 13 or 16%. And we also didn't find a difference in Clostridium infections. This is our graph. So as you see, in the group of patients who were on ciprofloxacin prophylaxis, the rate of bacteremia was significantly lower. And as you can see here, the most of the bacteremias occurred during the first 12 or so weeks of treatment. And because of this finding, it was decided to reinstate the use of ciprofloxacin prophylaxis in the summer of 2022. We are still going to analyze the data of the patients who started after the summer of 2022, so we're on prophylaxis, to see whether it led to a decrease of gram-negative bacteremia. This is still ongoing. So in conclusion, before I go to the final part of my talk, the febrile neutropenia guidelines differ, and sometimes there is a paucity of evidence. So a lot of the local information has to be taken into account to know what to do with the guidelines. The use of prophylaxis is still controversial, but it has been reinstated in the Maxima Center, and I hope to share with you our data in the future about whether or not this was successful. Finally, I was also asked to tell you a bit about our experience with invasive fungal disease in this patient group, and I will just show you some highlights from our experience in the past years. So this is the Maxima Center, and the Wilhelmina Children's Hospital is located just next to it. So in 2021, 724 patients were diagnosed with a malignant tumor. So as you can see, there are some new patients, but also some relapses. And here in this diagram, you can see the distribution among the hemato-oncology, solid tumors, and neuro-oncology groups. And when we look at risk factors for invasive fungal disease, as you will know, the most important risk factors are prolonged neutropenia, exposure to steroids, intensive chemotherapy for AML, but also, for instance, GVHD in the HSCT patients, very important risk factors. And the incidence in solid tumors is low, but in ALL it can be 5 to 10%, and in AML even up to 21%. One of our PhD students looked at the incidence of fungal infection in the ALL Dutch pediatric oncology group, patients who were treated according to the ALL 11 protocol. She looked at the patients who were included between 2012 and 2018. Those were 643 children. 7.3% of them developed a proven or probable invasive mold infection. So you see that there's some difference in the incidence that we find. When we look at specifically the group of allogeneic HSCT patients, a retrospective analysis of 209 children who were transplanted shows that the incidence of invasive fungal disease was around 12%, despite antifungal prophylaxis, which was first fluconazole until 2008, but later voriconazole. And they also showed, you can see the graph here, that patients who developed an invasive fungal disease had a significantly increased risk of treatment-related mortality. So it's very important to try and prevent them to get this invasive fungal disease. It will obviously lead to a lot of toxicity as well. I mentioned before that in solid tumors, it is very rare to see invasive fungal disease, but this is a picture of a boy who is now 4 years old, and he was diagnosed with a Wilms tumor stage 4 when he was 3. And he developed a very severe disseminated mucormycosis. So he had involvement of the lung, the liver, the kidney, and also the heart. So this is a very, well, I think surprising diagnosis for us, because we always say that in patients with solid tumors, it is very rare. But this patient had been neutropenic for quite some time. So we think that led to this disseminated mucormycosis. Surprisingly, this boy is currently stable. So he has been on combination therapy with amphotericin B and isofluconazole. And also he was treated with interferon gamma and nivolumab to try and control his infection, because it was getting worse despite the combination therapy. And now, finally, after several months, it seems to have come to a stop where the boy is very stable and the infection seems to subside somewhat. So this is a very interesting and very unusual case of disseminated mucorales infection. We have published a series of 10 cases who were diagnosed in the Maxima Center between 2018, when the Maxima Center was officially opened, to 2021. We saw 5 cases of disseminated mucormycosis, 4 localized to the lungs, and 1 localized renal infection. And when you look at the underlying diseases, they were ALL, AML, and lymphoma, so all hemato-oncology patients in that period. I mentioned before candidemias. We had one of our students look into yeast infections in the first 4 years of the Maxima Center, and she identified 35 cases of candidemia. And interestingly, the majority of these candidemias are non-albicans species. So you see the diagram here, where 1 in 5 of the candidemias is Candida parapsilosis. As you may know, parapsilosis is associated with a higher MIC for the echinocandins that we use for empiric therapy in candidemia. So it becomes a very challenging issue, because you cannot just start echinocandins as you would normally do. So in most cases, we have to resort to amphotericin, which is also related, associated with a lot of toxicity. So very interesting data. And what I haven't shown you here, but what is striking, is that many of the candidemias occur in the solid tumor patients, because they are not on anti-mold prophylaxis. So I think that would lead to an increase in Candida, invasive Candida risk. The presentation of invasive fungal disease can be highly variable. So we can have neutropenic patients who are severely ill, but we can also have patients who, despite a severe invasive fungal infection, are still very, well, not very ill. As you can see here, this girl had an invasive aspergillosis. We had to take her to the scan, which we had to do in the other hospital. So we had to go through the tunnel to get there. So as you can see here, her parents and the nurses were taking her there in her bed, but she was feeling so well that she said, no, I want to go on the bike instead. So the parents were pushing her bed and she was on the bike on her way to a scan, even though she had a severe invasive fungal infection. So the presentation can be extremely variable. These are some striking skin manifestations. So here you see a mucormycosis infection in a pediatric hemato-oncology patient. As you may know, it is necessary to do a very extensive excision for the mucor infection, because otherwise it might still spread. And here you see how the skin looks after the operation. This is a case of aspergillus, which is located on the lower part of the arm. And this is also an aspergillus infection of the upper leg. And this is also a very striking case of a fusarium infection of the buttocks. So very striking and very different presentations of fungal infections. The early presentation of invasive fungal disease can often be aspecific, so it can be difficult to pinpoint which patients have it and which don't. Of course, as you know, an important risk factor is a persistent fever, but also when a patient presents with cough or respiratory distress combined with a fever, nasal congestion, you should always think about a sinus involvement of especially mucormycosis, which is prone to give sinus infections, as you may know. And of course, increased inflammatory parameters might be associated with invasive fungal disease, although it can be very aspecific, especially in the neutropenic patients who have mucositis, with so many other reasons to have increased CRP. So early recognition, it remains a challenge. One of our PhD students also looked at the symptoms of patients with a proven or probable invasive mold disease. So as you can see here, the symptoms at presentation were mostly fever, but some of them also had some respiratory symptoms, and some had, when they had CNS, central nervous system involvement, they had neurological signs. And like I showed you before, some of our patients have presented with skin lesions. In this specific group that she looked at in the ALL cohort, 16 out of 47 children had CNS involvement, for which you see an example here. And in 8 of those, the symptoms were already present at presentation. So sometimes it takes some time for those symptoms to develop. And in some children, they might not even have any neurological symptoms. The MRI of the brain was routinely incorporated in the diagnostic workup. So whenever there is a suspicion of invasive fungal disease based upon the scan of the lungs, we will always proceed to do an MRI of the brain. So how do we diagnose it? Because it's so different. We look at serum galactomannan, although that is not a very good marker, especially in patients who are on prophylaxis. Like I said before, in persistent fever of 96 hours, we will do a high-resolution CT scan of the thorax, and we might proceed to do a bronchoalveolar lavage in patients who have significant findings suggestive of fungal disease. Very briefly, like I said before, can we use the markers like serum galactomannan or beta-D-glucan? Well, many studies have looked at this, but the sensitivity is relatively poor, especially when you look at the patients who are on prophylaxis. This was an ALL cohort with 47 patients with aspergillosis, and 15 patients out of 42 had a positive serum galactomannan. So you would miss a lot of the patients if you would just base it on the positive serum galactomannan. You probably know the classic scans that are associated with fungal infections. The halo sign is very suggestive, and also the air crescent sign, as you see on the right side. Those are all classic and very easy scans, so to say, to look for a fungal infection. But most of the times the signs are much more aspecific, and it can be very difficult to separate the fungal infections from other pulmonary infections, as you can see here. One of our radiologists has looked into this. So they try to differentiate between fungal and non-fungal infections using CT. So they looked at children with malignancy who were diagnosed with a pulmonary fungal infection, or a non-fungal pulmonary infection to look at the differences. So the CT scans of the time of presentation were anonymized and then blindly assessed using a scoring form. And they included 48 patients with pulmonary fungal infection and 37 with non-fungal pulmonary infections. The results are shown here. So on the left part of the table, you see the fungal infections, and on the right part, you see the control patients. As you can see, the most important differences are, like I showed you in the two previous slides, the nodules and the halo sign, which are characteristic of a fungal infection. But as you can see, the consolidations can make it very difficult, because in the control patients, most of them had consolidations, but also in the fungal infection patients, there were a lot of consolidations. So this also always leads to a lot of discussion. When they looked at the subjective assessment of the CT scans to say, is this low, intermediate, or highly probable for a fungal infection, then you can see that in the actual fungal infections, almost 60% of the scans are assessed as highly suggestive. So that means that about 40% are not. And in control patients, it is a bit more, it is a bit easier to say that it is not a fungal infection, but still not unanimously. Like I said before, we do a BAL whenever we suspect a fungal infection. When we get the BAL, the microbiologist will do direct microscopy, and they will also do a galactomannan on the BAL. They will do Aspergillus PCR and also do PCRs for resistance mutations. They will also do Mucorales PCR and fungal cultures. Sadly, the cultures often lead to negative results. Also the PCRs, by the way. So approximately 50% of the children are treated with antifungal agents for a possible invasive fungal disease. And this is very frustrating, because obviously the antifungal agents might lead to toxicity. So we are still searching for a better way to either confirm the diagnosis of invasive fungal disease or to be able to stop the antifungals. The guidelines still advise to give antifungal prophylaxis in patients who are at high risk, which is commonly defined as an incidence of at least 10%. I showed you before that in our ALL cohort, the incidence is around that number. And when we further look into the guideline, there are strong recommendations for antifungal prophylaxis in children with AML, but also the allogeneic HSCT patients before they are engrafted, and also those on systemic immunosuppression for GVHD. For children, either an echinocandin or voriconazole or itraconazole is suggested. So there are different types of azoles that we use here in the Maxima Center. And in older children, posaconazole, which is yet another azole, can also be used. As of 2013, in the Netherlands, we started, whenever we start empirical therapy for invasive fungal disease, we will give a combination of MFOB and voriconazole. This is based on the fact that we see a lot of azole-resistant Aspergillus. Azole resistance is especially high in the Netherlands because of the use of azoles in agriculture. So we have up to 15% of our Aspergillus isolates that are resistant. Yeah, this is just to show you that we use voriconazole in the empirical treatment, but it shows a highly variable plasma concentration. So it is very difficult to use voriconazole in children, especially the younger ones, because we need to do very regular trough levels to get them to a stable treatment level. And then finally, I just wanted to share this paper with you. This is a paper in which we looked at patients who were still under treatment for invasive fungal infection, but who despite this went through an allogeneic stem cell transplantation. So we looked at the patients between 2012 and 2020. There were 317 patients who had an HSCT, and 23 of them had an active or recent probable or proven fungal infection. So recent would be within 6 months before transplant. And then 1 year after their transplantation, most of them were still alive. So this, I think, is very good news because it shows that even if you have still an active fungal infection, it is possible to do the transplant. 4 out of 5 patients who had died of non-fungal infection-related causes, and 1 patient died because they newly developed an invasive fungal infection after the transplant. And then there were 3 patients who showed progression of their original fungal infection, but this did not lead to mortality. So it is challenging, but it is doable in this cohort. So to conclude, children receiving intensive chemotherapy have a high risk for invasive fungal disease. And we have seen this in the Maxima Center. The clinical presentation can be very diverse. It is difficult to diagnose it. So often we treat them for possible infection. And the recommendation for antifungal prophylaxis in high-risk patients still stands. And with this, I would like to conclude my talk. And I think we go back to you, Dr. Susi.
Okay. Yeah. Okay, thank you, Dr. Lieke, for your comprehensive presentations. Maybe to link the Dr. Lieke's lecture with implementation in our patient, Dr. Sandra and Dr. Sindy will present several cases of pediatric cancer with febrile neutropenia. Maybe for the first case, Dr. Sandra, your time to present your case.
Thank you, Prof. Susi and Dr. Lieke and all participants here. Will it be Dr. Sindy first or me? Yeah.
Yeah, I will start the first case. So this case is a 1-year-old boy with TALL, acute lymphoblastic leukemia T-type, was in his consolidation phase of chemotherapy, and he he had received high dose methotrexate with doses 2 grams per meter square, and after the chemotherapy is finished, he came with 3 days of fever, high-grade fever, 39 degrees of Celsius, and also mouth ulcers and feeding difficulty. And we thought this patient diagnosis would be grade 3 mucositis. And this is his lab finding. So his hemoglobin level was 7, leukocyte count was 880 with thrombocyte 42,000. So he is pancytopenia with diff count with low neutrophil, band neutrophil was 2, and the segmented neutrophil was 35. So the discussion of this case, how will you proceed this case, and when will you give antibiotics, and what type of antibiotics will you give to this patient? So we have this guideline. So we will talk about the pro and contra about the question about the proceed the antibiotic intravena in this case. So maybe we decided to give antibiotic for this case because it's very feasible to implement, and hospital policy is also accept as long as already established the guideline is present. But the contradictive one is it will make a high cost, and the culture result might be sterile or negative. So maybe Prof. Susi, you will lead the discussion.
Yeah, okay, thank you, Dr. Sindy. Maybe I will invite our pediatric infectious disease consultant. Okay. Yeah, I will invite.
Yeah.
Dr. Djatnika, maybe.
Yeah, thank you, Prof. Susi. I think first we decide is this case had febrile neutropenia or not. Firstly, but I think for this patient had fever 39 degree and also had neutropenia maybe less than 500, I think. Yeah. So this case, according to the definition, had febrile neutropenia and also maybe some risk factor, high risk because some mucositis and also had high dose MTX. I think agree with high risk febrile neutropenia and give antibiotic firstly.
Okay.
But for the second examination for blood culture, it is in our hospital maybe some kekurangan some
limitation,
or obstacle for doing blood culture in emergency. I think it's my opinion.
Okay, thank you, Dr. Djatnika. So the first we have to decide is this this patient suffer from febrile neutropenia? Maybe we have to deal with our definition, Dr. Djatnika, when we decided is febrile neutropenia or not in this patient. Maybe for other consultant of pediatric infectious disease, give a comment or maybe the.
Yes, thank you, Dr. Prof. Susi.
Yeah, Dr. Anggi, thank you.
According to febrile neutropenia definition, we use oral temperature for the definition. So what's our suggestion? If we measure the temperature, the body temperature with axilla, is it still 38 degree or 38.5 or less than oral temperature such as 37.5? Maybe about that.
Maybe practically, Dr. Anggi, we use mostly axillary temperature. Okay, so maybe we have to make a deal how the conversion. Yeah. Okay, maybe the others can give the comment.
Prof. Susi,
yeah,
may I have a comment?
Thank you, Dr. Ida. Welcome. Yeah. So maybe how is your experience in Yogyakarta? Do you also use oral temperature for assessing the body temperature of the patients? Or
no, I
like
think in practical, yes, in practical we use axillary measurement for the temperature. Yeah, and I do agree with Dr. Djatnika that we should decide first whether this is febrile neutropenia or not based on the data that presented by Dr. Sindy. I think it's fulfilled for the definition of febrile neutropenia. I guess that it's high risk febrile neutropenia. And in Dr. Sarjito Hospital also, we have some obstacle in terms of providing blood culture in ER. So usually blood culture will be provided after the patient admitted to the ward. Thank you.
I think we had the same condition, yeah, quietly the same condition regarding the maybe the regulation and so on, yeah. But Dr. Like's presentation, it will be better. Maybe it is recommended to give to take the blood culture before giving antibiotic, yeah. Okay, what's your comment, Dr. Lieke?
Yeah, I fully agree. I think you are right. This is a case of febrile neutropenia. And I totally agree with the comments by the ID physicians to start antibiotics. And like you said, you would preferably have blood cultures before you start it, because then if the cultures remain negative, you might be able to discontinue the antibiotics as soon as the patients are afebrile. And I was just wondering, I have a question. Why is it possible to do the blood culture in the ward and not in the emergency department? I was just wondering.
Okay, maybe Dr. Anggi, Dr. Anggi
The problem,
will answer our problem.
yeah, problem is we have a government insurance for all of the patient, so they have to have the medical record first, and takes time. So maybe it takes some time. So therefore, it is not easy to draw blood culture in the ER. Lieke, do you perform one or two blood culture, two side of blood culture for our febrile neutropenia patient? And my first questions, how about the axillary culture? Second question about the one or two side of blood culture for a febrile neutropenic patient. And in this patient, instead of just ask about mucositis or find out about it, how about the neutropenic enterocolitis? So we have to ask the possibility of NA or neutropenic enterocolitis or nephritis in this patient, but it is not easy for young children. So what do you do? Do you do you check the abdominal sound to find out any sign of nephritis, or it is just if this patient have abdominal pain or another sign and symptom? Thank you, Prof. Thank you, Lieke.
You have some comment with Dr. Anggi's question?
Yeah, thanks very much, Dr. Anggi, for your question. They are very relevant and very good questions. And also thanks for clearing up. I didn't know that the BPJS issues relate to taking blood cultures as well. No, so your first question was regarding the blood cultures. We do only take blood cultures from the central venous line. So back in I think maybe 10 or 15 years ago, we used to take 2 blood cultures, so one from the central line, from each lumen of the central line, and then one from like a peripheral plug. But we have decided against it because it will take, well, it is a lot of effort, of course, to have to take another blood culture from these children. So we only do the central line, and all of the pediatric oncology patients will have a central line. And we will do, so we have 2 sets of blood cultures for children who are over 4 years of age. So we do the anaerobic and the aerobic bottles. And then for children who are younger than 4, we have pediatric bottles, so they are not the anaerobic cultures. And the second question you posed was regarding typhlitis, which is a very important question. We start by doing a clinical assessment. So whenever there is diarrhea or abdominal pain, we will do a clinical examination to see whether the belly is distended or painful. And if we are in doubt, we will proceed to do an ultrasound to see whether there's any signs of neutropenic enterocolitis. I think Judith wants to, maybe Judith wants to add to.
Yes, if you have
Well,
hepatitis patient, is it regular to check ultrasound, or we have to find out another sign and symptom of nephritis? If you have patient like this with mucositis, is it the possibility of nephritis quite high, or it is not it's not correlate with the nephritis?
It doesn't need to correlate because the oral mucositis can be present, for example, in a high-dose MTX, and it doesn't need to be that the whole gastrointestinal tract is having problems with that. But if you have a clinic of a patient indeed with an enlarged distended abdomen or painful or frequent diarrhea all the time, it is suggestive of at least mucositis. And then the question is, should you add that suspicion already to your empirical treatment of your febrile neutropenia? And that depends on what you choose as your upfront treatment, right? Because Lieke just showed that Cefta is one of the possibilities, but for example, piperacillin tazobactam is also one of the options. And the second one already covers the anaerobes as well. So if we are not sure and we cannot fully rule out, when we are in doubt, my experience is that we cover anaerobic as well. Do you agree, Lieke?
Yeah, I fully agree, Judith. So we would only cover anaerobes if we have signs or symptoms of a possible typhlitis. And if we are in doubt, we would do the ultrasound. But it is not that we would do the ultrasound upfront in any patient with just oral mucositis.
Okay, thank you. And how about to take the body temperature? We use axilla. So the definition of febrile neutropenia is still 38 or 8.5 degrees Celsius.
Dr.
We do
Anggraini,
the same.
Maybe, we will make a conversion between, maybe if it is not feasible in our practical daily practice, in Indonesia, Dr. Ida also said that in Yogyakarta use axillary temperature also. So maybe in our guidelines we will make conversion about the type of assessment. If maybe using the oral temperature, the point like this, and then maybe we will conversion with axillary temperature, maybe, because we have to make our recommendation based on we have to feasible. Okay, before
Prof. Susi. Prof. Susi.
Dr. Djatnika.
For Dr. Lieke, in some recommendation, if there is some mucositis, we just give antifungal drug. Is right or depend on the other clinical manifestation?
Okay, maybe Dr. Lieke. Practically, we often find the children with febrile neutropenia with the presentation oral mucositis. We often give the patient maybe like nystatin, something like that, Dr. Djatnika.
Oh no, antifungal, yeah.
Yeah, antifungal
Drug.
topically and also maybe
Oral antifungal.
orally. What's your opinion?
Orally or intravenously?
Sometimes intravenously, in maybe in severely ill, we use intravenously.
Yeah, thanks very much, Dr. Djatnika. It's a very important question. I agree it can sometimes be challenging to distinguish regular mucositis orally from also a co-infection with yeast. So what we would do, we would not empirically treat yeast infection. Sometimes when there is a doubt upon clinical examination, so for instance, when there are white plaques, right, or any other signs suggestive of thrush, so to say, then we would, so oral thrush, then we would start by giving either local treatment with nystatin, like you say, because with nystatin, the spectrum of treatment would be similar to amphotericin B, so it would also include the Candida species, which would maybe not be susceptible to fluconazole. But whenever we suspect a severe co-infection with yeast, we might proceed to give intravenous fluconazole. We would always take a culture if we suspect a yeast infection, and then we would guide our antifungal treatment accordingly. So I would not start it up front, but only if you have clinical signs suggestive of it. Yeah.
Okay, thank you, Dr.
Thank you.
Lieke. Maybe we will go back to the basic. Yeah. The first we do agree that first we have to make definition of deal with definition of febrile neutropenia, and then we have to decide is it low risk or high risk. Maybe I invite Dr. Nur Melani, who has write down your question in chat to deliver your question directly. Maybe represented by for pediatric oncologist perspective, Dr. Sari.
Yeah, thank you, Prof. Susi. As Dr. Sindy has been shared screen in the recent publications, there are several criteria for defining high risk and low risk. So usually we, and the historical perspective, we usually use the adult way to do classification. And nowadays we have like at least 3 validated score. And in your opinion, in PMC, which of those criteria, maybe Dr. Sindy can backward a little bit about the
case,
the screenshot of the possibility of this one.
Okay.
Yeah, because it's when use these, usually we use the, maybe Dr. Anggi more familiar with adult, and I am too more familiar the way like how adult oncology patient differentiated. So if we will use these, is it like have like advantage that the previous classifications? What or which are the most important things? Thank you, Dr. Prof. Susi.
Yeah, Dr. Sari, you make comparison between adult and pediatric, but I think in Dr. Lieke's lecture, also after we decided the definition of the patient is suffer from neutropenia, febrile neutropenia or not, and we continue to make the stratification. So in this case, what's the state of the patient? Low risk or high risk febrile neutropenia? Because I think it's quite important decision. The stratification will guide us to choose the empirical antibiotic. Is it okay, Dr. Lieke?
Yeah, so like I showed you before, in the Netherlands, because there is so little data about the feasibility and especially the efficacy of oral antibiotic treatment, our working group has decided to not take this risk stratification into account. So in the Netherlands, whenever a child presents, an oncology patient presents with fever in neutropenia, we will always proceed to do blood cultures and start them on broad spectrum IV antibiotics. But we will, if they are not ill and if the blood culture remains negative, we will discontinue the antibiotics again. So I realized that in your setting, it would be more important to be able to give outpatient antibiotics, like you also mentioned, in view of the costs and the insurance, the BPJS. So, but this is something that we do not, we do not use this risk stratification.
Okay.
Susi,
Yeah.
may I? Yeah,
Yeah.
may I add something? Yeah. Thank you, Lieke. Yeah, I know that, as you mentioned, in Netherlands, you don't need to differentiate whether this is low risk or high risk or standard risk, and then you proceed to give intravenously antibiotic for all of the febrile neutropenia, right? But in our setting, like in Dr. Sajita Hospital, we discussed with the colleague from hemato-oncology, and we developed also PPK. PPK is like a standard treatment that is implemented in our hospital. We need to differentiate whether this is a low risk or high risk, because it is also related to the logistic, because I think it's not possible for us to admit all of the patient with febrile neutropenia to our hospital and giving the IV antibiotic. So that's why this is also part of our concern, that we need to differentiate between which is the one that low risk and which one is the high risk. That's all part of our consideration. I think Dr. Bambang Ari will maybe add some about how to differentiate between low risk and high risk. Thank you.
Yeah, thank you.
Okay. Yeah, Dr. Bambang, maybe you will deliver also your chat, directly.
Yeah, we have some challenges to diagnose whether this patient fulfill the definition of febrile neutropenia or not. If we are looking at the previous literature, that the definition of neutropenia should be less than 500 or 0.5. But in our set, sometimes we receive patients with the ANC of between 0.5 to 1.5, and then this patient was then considered as febrile neutropenia. The challenges is that the patients came to our hospital not in the first hours after the onset of fever, but the patient came after a couple of days without any antibiotics at home, and we are thinking that we have to make an urgent administration of the antibiotics. And then I agree with Dr. Ida that in our setting we have to differentiate whether it is high risk or low risk of febrile neutropenia. But since in Sarjito we are using the invasive bacterial infection scoring system, and some of the parameters which have to be checked is the CRP, and sometimes it needs a couple of almost 2 hours when you're checking it in the ER.
Maybe in our setting, we agree, make recommendation to stratify the febrile neutropenia, Dr. Bambang. It is possible to use in our setting.
Yeah, okay. I think we have to.
It is not difficult.
Yeah, I think we have to propose some stratification, risk stratification system which is feasible in our setting.
Okay.
But can I ask a question? Because if I understood the guideline correctly,
Dr. Judith,
all these studies
maybe
who use this stratification for low risk or high risk.
Would you like
Actually,
to repeat your question?
oh, yes, thank you. If I understood the article correctly, the risk stratification systems that are being used are not used upfront. So all children are admitted and get IV antibiotics. The low risk or high risk stratification is only used, as Lieke also mentioned, to decide whether you can switch to oral or not in 24 to 48 hours. Is that correct?
Dr. Bambang? Or maybe other, yeah, Dr. Bambang, you
Yeah, usually we did the stratification before we gave the first dose of antibiotics, but since it needs a long time for getting the results, even for the neutrophil counts and also the CRP, we assume that all of the admitted patients are having febrile neutropenia, so we gave the intravenous antibiotics and admitted to the ward. But I do realize that this is not a good practice for doing so.
No, but I mean not specific for the Sargito. I mean these validated studies that are mentioned here all administer the patient to the ward with IV antibiotics. The validation scores are only used to decide whether you can switch to the oral after, for example, 24 hours, depending on each of these different studies, and then closely follow up in the outpatient. Or whether you say, no, it's high risk, we cannot do that, and we should continue with the IV antibiotics in the hospital.
Prof. Susi,
yeah.
may I clear this contribution? So we have two options, Judith. Once, as Dr. Bambang said, in Sarjito and maybe also in Hasan Sadikin Bandung, sometimes or maybe later, many febrile neutropenia patients came to our hospital and we have we have limitation of bed. So we have to make maybe new stratification. So such Lieke Boehner said in 2023, many patients, or Santolaya said, many patients, febrile neutropenia patient came and the etiology are viral infections. So we have to stratify to low and high febrile neutropenia, and maybe the low FN that have no ward and can hospitalize, they can send home with
oral antibiotic
for FN low risk, maybe like that. So we have three what I said risk index for febrile neutropenia, MASCC for adult, and also CISNA, CISNA, how to say that, and also Santolaya. So which one we can use, because three of this risk index used to assess maybe complication and other. So maybe it's not for antibiotic use, but most three of them mostly for prognosis of the patient.
Okay, Dr. Anggi, maybe what happened in Western country is quite different with our in our setting, but there are some guidelines, maybe Judith and Dr. Lieke, who for the patient pediatric cancer, yeah. So maybe we will modify based on our availability and so on and so on, because maybe we have no national guidelines based on cohort, maybe based on the multi-center study and so on and so on. Yes, so we have to modify for our setting. Yeah, I think it is very interesting discussion, but we have to move maybe you know, to other question. Yeah,
yeah, Prof. Susi, maybe the most important thing for this case, maybe there is no discuss yet. So what antibiotic?
Yeah, we will move to answer the Dr. Sindy's case. Yeah. Okay, maybe Dr. Sindy, you will share your case. So for this case, what's your suggestion? Maybe previous slide. The question. Yeah. Okay, how about the treatment for our setting? Maybe what's your opinion, Dr. Nur Suryawan?
Yeah, as we know, if you have a patient with a febrile neutropenia high risk, and we go to giving antibiotic intravenous, and we in Hasan Sadikin we give Setiabudi intravenous IV, yeah.
And the patient, we decided that the patient suffer from high risk febrile neutropenia, Dr. Suryawan, and the patient is hospitalized in our ward.
And give antibiotic, and we'll see what the response after we give the IV antibiotic.
Okay, and we will evaluate the response. Maybe the first stable or not stable, to decide the patient stable or stable. And then what's your question later, Dr. Sindy? Dr. Sindy.
Maybe in the chat Q&A box, we have several questions, Prof.
No, we focus on your case first.
My case is already
okay. What's your opinion, Dr. Lieke? Is it do you agree that we will hospitalize this patient with high risk febrile neutropenia? We use ceftazidime intravenously, and we will evaluate and follow up this patient.
Yeah, I fully agree. Like I mentioned before, so I agree with starting them on ceftazidime. I would take into account the mucositis, though. I cannot see from the picture, but it looks quite severe. And like it also said, the patient has some ulcers, so I would add gram-positive cover in this case. So in the Netherlands, we would give vancomycin. If the patient is on ceftazidime for febrile neutropenia and there is severe mucositis, we would add vancomycin.
Okay, thank you, Dr. Lieke. Is it that's all for your case, Dr. Sindy?
Then it's maybe nice to hear from the Indonesian perspective, because I understood vancomycin is a restricted antibiotic.
Yeah.
So what would be other options to choose for high-risk febrile neutropenia for gram-positive coverage besides the ceftazidime that you already started? Or would you like to switch?
Prof, may I have another opinion about the antibiotic choice?
Yeah.
We prefer to give cefepime. Why? It is not just for antipseudomonal, but also for gram-positive microbe. So of oral microbial that usually found in febrile neutropenia patient or cancer patient is Streptococcus viridans. One or two studies show cefepime superior than ceftazidime in covered Streptococcus viridans. And here in Bandung, we reserve vancomycin for patients with very severe illness. If the patient gets shocked or the patient showed the MRSA infection. Thank you, Prof.
Yeah, Judith, in our setting, the first we give antibiotic ceftazidime IV, and then if there is no, maybe the response is not good, we will use cefepime, Dr. Anggi, IV, and then vancomycin. The most important of the usage of antibiotic is availability. I think for cefepime always available, yeah, Dr. Anggi, yeah? Hello?
Yes, Prof. It is not easy to find or to get vancomycin here.
Okay, yeah. Okay,
Yeah,
maybe
so I think Dr. Anggi is stressing that if you have a child which you suspect also for maybe a gram-positive infection, like the child miracle treatments, choice of her would not be the ceftazidime, but the cefepime, because then you also cover the Streptococcus mitis. And thank you very much for that suggestion. That's a really good suggestion. And I was really interested, maybe in other hospitals, what the upfront treatment choice would be if you have a febrile neutropenic patient with an oral mucositis.
Okay, thank you, Judith. We will move to the question in the at the chat box, yeah, from Dr. Fatima Saidah. Dr. Fatima Saidah, hello.
Yes, Susi.
Your question, you can ask directly, maybe, Dr. Fatima.
Okay. Okay, thank you. I would like to ask, I know in Princess Maxima you choose strip cyprofloxacin, but I think in our country the easiest access is to cotrimoxazole, but I want to know if you want to use cotrimoxazole for prophylaxis in leukemia induction, where the patient are usually still in pancytopenia. Do you give it regardless of the neutrophil count, or do you have the cutoff of the permissible neutrophil count to give, considering the possible side effect of granulocytopenia in cotrimoxazole?
Okay, maybe regarding the Bactrim or cotrimoxazole has side effect of granulocytopenia. So what's your suggestion about the use cotrimoxazole for prophylaxis, Dr. Lieke?
Yeah, it's also a very important question. There are some studies showing that cotrimoxazole is also an agent that is used for prophylaxis. The downside, of course, is that it will not cover Pseudomonas aeruginosa. But again, there are many studies that have used cotrimoxazole. I think in the HSCT patients, we use cotrimoxazole for PJP prophylaxis, and we will not give it before they have engrafted. So we will only start after maybe 4 to 6 weeks after their transplantation. So I know that there's an absolute contraindication to give it in those patients. I would have to say in ALL patients that I don't think that there would be much reason to not give it necessarily in terms of the neutropenia. I think the effect might be there, but you would still expect the neutrophils to go up. So that is regarding the neutropenia. But I still think that all the guidelines still recommend the quinolones as the first choice. But I do agree, it is one of the options as treatment. And we also used to give it, I think it was 15 or so years ago, we also gave cotrimoxazole to the HSCT patients as a prophylaxis.
Okay, so if we need antibiotic prophylaxis, but the patient is maybe considered that has side effect of granulocytopenia from of blood cream. What other we use other antibiotic, Dr. Lieke?
I'm sorry, I couldn't follow your question because there was some background. Can you briefly repeat it?
Okay. Let's say, as Dr. Fatima said that the patient need prophylaxis antibiotic, but with neutropenia, we cannot use cotrimoxazole or maybe in your country Bactrim. Yeah, what's other choice?
Yeah, so like I said, we use ciprofloxacin, and the guideline, the Lernberger group advises levofloxacin, which also has the advantage of more gram-positive cover. Do you have access to levofloxacin in your country?
Yeah, I think it's available. Yeah, easy. Yeah, ciprofloxacin. Okay, we will move to other question. Maybe the last question for the first case from Dr. Ganda Ilmana. What is the consideration for using GCSF in neutropenic ELL patient during chemotherapy? Maybe from Dr. Bambang. What's your experience using GCSF in neutropenic ELL patients during chemotherapy?
Yeah, previously long times ago, we are giving GCSF for all patients with febrile neutropenia. But when we read some literature that GCSF is not completely solve the neutrophil count because of it partially works on the differentiation pathway of the neutrophils. We stopped the administration of GCSF in ALL and AML.
Okay, what's your comment, Dr. Lieke?
Yeah, I think maybe I think Judith knows even more about this, about the because from the oncology point of view, I still think that if you can get your hands on levofloxacin or ciprofloxacin, that would be preferable. But I can imagine if you don't have anything else that you would give cotrimoxazole. And for the addition of GCSF,
maybe to add to that, so for all leukemia induction patients, we use triple infection prophylaxis. So we not only give ciproxin, we don't have the levofloxacin, as bacterial infection prophylaxis, but on top of that, we give 3 days per week cotrimoxazole as PEP prevention prophylaxis. And we give an antifungal treatment to that.
Yeah, I think we are now talking about cotrimoxazole as antibacterial prophylaxis, right?
Yeah. So you can, if that has been used and you cannot use the levofloxacin or the cipro, you can think of doing that, but then it should be daily, right?
Correct.
Okay, Dr. Bambang, it's okay. Okay, I think I will close the first case. Is it possible, Dr. Sandra, to present your second case?
Yeah, sure, Prof. We already all have the same question for the participants here, just like Dr. Ganda questions. Well, this is the second case. We have a 6-year-old girl. She came to our outpatient clinic to have the routine follow-up for standardized ALL. She was in maintenance phase. Okay. So she came with a fever without cough and diarrhea, and her appetite was good. But during the examination, we confirmed that the temperature was 39 degrees, no mucositis, and she was clinically stable. Right? Boleh di-mute ya. Ya, oke, terima kasih. She was prescribed the oral methotrexate, 6 mercaptopurine, and the PCV prophylaxis. The lab result shows as below. The hemoglobin was good, 12. The white blood cell count slightly decreased, 1,200, with normal platelet counts. And let's see what we are discussing. Next slide. Should we admit the patients to the pediatric ward and give IV antibiotics? Because the leukocytes count was 1,200. We have pros opinions that yes, we should admit the patient to the ward and give IV antibiotic because we can create an isolated environment to protect the patient from the other sources of infections. And we can ensure that the adequate level of IV antibiotic during the hospitalization. And we can do the daily evaluation of infectious progression in this patient. But then we have another contradictory opinion that in a low-risk septicemia patient, the outpatient IV or oral antibiotic will yield the same quality as the hospitalized patients with intravenous antibiotics. And there's some research that shows the higher quality of life was found in outpatient setting. So this is the first question. Should we admit to pediatric ward or should we do outpatient visit regularly?
Okay. So what's your opinion? Maybe from Dr. Lieke or Judith?
Yeah, I don't know. Lieke, do you want to start or shall I start?
Go ahead, Judith.
Yeah, so this is this is a patient in the maintenance of the ALL, where we try to keep the leukocytes between 2 and 4 and still having chemo, the 6MP and the MTX, if I was right. So this is not a patient having a severe deep neutropenia. And actually you can think if the patient is clinically really well, only having the fever, of course, we always want to know what is the focus of the fever. So that helps us in decision making. But this is formally not yet neutropenic fever. And sometimes we say, like Dr. Adi mentioned, maybe we should not be too strict on the 0.5 or the 500 in Indonesia. But in this case, you know that if you actually would stop the 6MP and the MTX, that the cell count will go up again. So there is no risk that you don't expect in this case that tomorrow, the day after, there will be a deep neutropenic patient. And if the patient is clinically well, having only the fever, and you can stop the oral chemotherapy treatment, I would consider this patient as treat this patient as an outpatient patient, if I explain myself well. And I would try to look for the source of the infection and try to culture anything possible. And the minimal we do, but that is of course because most of our patients have central lines, the minimal we would do is then do a blood culture also, but not even directly start, but follow up on that culture. And if we send the patient home, so consider clinically well, no focus for the fever, and in the lab also no abnormalities, no really high CRP, things like that, then we would, of course, have a close contact and see the patient again, or at least talk to the patient in the next morning or something like that.
So you will do the daily evaluation on the outpatient clinic?
Yeah.
Okay.
But then if you can really say, no neutropenia, I will stop my chemo, I'll expect the leukocytes to go up, the clinic well, and no specific focus, that helps me in thinking, oh yeah, this is really bacterial infection. And do the minimal cultures needed if you have things like an in our case a central line.
And you will evaluate this patient within how many days?
Yeah, so we will call the patient, or we consider if the
3 to
patient
5
may
days.
consider asking them to go to the shared care for a new evaluation the day after.
The day after. Okay.
Okay. Anything? Any comment for this? Oh.
Yeah, Dr. Prof.
Yeah,
Susi.
Dr. Nur Suryawan.
Yeah, yeah, I agree that this is I will if giving oral antibiotic to give to the outpatient outpatient department, and I agree with Judith that the methotrexate oral and mercaptopurine will we have reduced, not stop, but we reduce 50% of dose of methotrexate and mercaptopurine, because the absolute neutrophil count is more than 500, more than 500, but below 750. So we have to reduce the oral chemotherapy, not stop, but reduce until 50%.
Okay.
Well, Dr. Nur or Prof. Susi, what about the PCP prophylaxis? We know that cotrimoxazole also may be causing the decreasing of leukocyte count. Will you still give the cotrimoxazole or stop it at the same time?
What's your opinion, Dr. Maybe Dr. Judith?
Yeah, so actually we never stop the co-trim, so it's a different approach.
In maintenance pace, still 3 days in a week.
Yes.
Okay.
Yeah.
Okay, Dr. Sandra, do you still have any slides for your case?
Well, after this we have the question for the GCSF.
Okay, I
Only
think
for
we
the
have
GCSF.
discussed earlier, but maybe what's your opinion, maybe Dr. Melani Sari, about pro and contra in using GSF for febrile neutropenia in pediatric cancer, or in this case, ELL patient standard is in maintain pace. Hello.
Yeah, thank you, Prof. Susi. As not as long as short as I read in the previous publications, there are no difference between giving GCFF or not, in spite of the outcomes. And some of literature said it's just increasing of relapses. So we have to see the clinical base. Is it like patients in the life-threatening condition like sepsis who need really like ventilator, or in the inotropic support? So if this case like the previous one, the clinically stable, and we can do the follow-up in outpatients, I guess for the evidence-based report, we didn't use, and also for the cost, also it's not like cost-friendly. But if the conditions, we possibly can use, but I don't sure if it's any in a research base, is that any influence on the outcomes?
Discussion. Okay. To all participants, I think the time is up. Dr. Sandra, is it enough for your case?
Yes, thank you, Prof.
Yeah. Maybe from Dr. Lieke, you have closing remark, summarize for our discussion.
Yeah, I'm very excited and very impressed with your suggestions. I think to summarize, we have realized that febrile neutropenia is always a reason to carefully consider taking blood cultures and starting IV antibiotics. I have learned that in your setting, this can be very challenging, and I understand the need for a risk stratification in your setting. So I think maybe I'm also looking at Judith. Maybe in future we can discuss what would be the most feasible approach for you to do this in your setting. And I would be very happy to help if I can in any way. So thanks very much. I'm very grateful that I was able to join this.
Okay, thank you, Dr. Lieke. I definitely agree that this discussion seems to serve as an initial pace, yeah, as trigger to be followed by a subsequent discussion, more intense, with working group of hematology oncology in Indonesia, Pediatric Indonesian Pediatric Society, and the working group of infectious disease and tropical medicine, maybe Dr. Anggi, to discuss thoroughly in managing febrile neutropenia in children with cancer, because it is not enough time in 1-2 hours to discuss everything, because we hope we will have a national guideline, yeah, who can which can maybe which affordable, and ideally we do agree that we must have maybe the agent pattern, the pattern of resistancy and sensitivity to antibiotic, but also we have to compromise with our regulations, yeah, for both our health insurance and also maybe for the hospital regulations. How about this statement, Dr. Bambang, for Yogyakarta, from Yogyakarta? Maybe you have another insight regarding this, because it is, I think it is a very important or crucial topic, yeah, because most of the morbidity patient, leukemic patient in pediatric is due to infection. What's your opinion in the last session, Dr. Bambang?
Yeah, I agree with what Prof. Susi said. We have to tackle this infection problems, and we have to deal with the regulation of the hospital. Okay. I think at first we have to propose some adapted risk stratification for differentiating whether the patient is high risk or low risk of neutropenia. We have to, and then we can save our pets for the patients in need.
Okay, maybe the last statement, maybe closing remark from Dr. Anggi as the chief of working group of infectious disease and tropical medicine in Indonesian Pediatric Society regarding our topic.
Thank you so much, Prof. It is the best opportunity for infectious disease working group of Indonesian Pediatric Society, with collaboration with hemato-oncology working group, and also Prince Maxima, Lieke, and Judith. And in Indonesia, for infectious problem, it's very high and common. Besides the microorganism, that the problem for neutropenic cancer, neutropenic patient. Also in Indonesia, we have many kinds of infectious disease. We are in the tropical country, so typhoid fever, dengue fever. So we need a diagnostic test, appropriate diagnostic test for our pediatric cancer with febrile fever sign and symptom. Thank you so much, Prof. Susi, for include for our participation from infectious disease. I hope this is just for the first session for us, and within another session, you may invite us, and the collaboration will be very close in the further session, such like Dr. Riyadi have already a concern in infectious disease and hematology. He is already settled in Sinjut because of collaboration of our division, infectious disease, with hematology oncology division. Thank you so much, Prof.
Thank you, Dr. Anggi. The last I will invite Dr. Riyadi. Sorry, we will see. What's your comment about this?
Yeah, thank you, Prof, for the opportunity, and thank you, Lieke and Judith, for your presentation. I think today's session is very useful, so we can collaborate, and also we can find the best treatment that can fit for both our world. The Netherlands that have so many supporting things, so many things that, like Judith says, in last case that Sandra presented, maybe it will be a little bit different if the case is happening in Indonesia because of the social problem, how to manage, how to prevent the infection. If the patient is taken home, it will be such a problem in Indonesia. So I think we should found the best way to treat our patient, and also the best way to treat and to have an antibiogram, the best possible antibiotic that could fit our setting, and also maybe it also can be used for your setting. That's all for me, Prof. Susi. Thank you for the opportunity.
Thank you, Dr. Riyadi. So maybe Lieke and Judith and Dr. Anggi and friends, we have to make a special agenda to discuss this topic, yeah, because I think we need longer session, yeah, for discussing this problem. Okay, hopefully this session will give benefit for us in handling our pediatric cancer patient, and we're confident that together we will improve our pediatric oncology services. Yeah, step by step, we will maybe make national guidelines regarding this, and we will invite maybe the team from Maxima Hospital, yeah, later, yeah, and this collaboration, yeah, between the two other working group in Indonesia, in Indonesia, will continue in establishing again national guidelines in diagnosis, yeah, and management in neutropenia, fever, and or febrile neutropenia in pediatric cancer patient. Finally, to all experts, panelists, doctors, and all participants who have already participated in this interesting discussion, I would like to extend my deepest gratitude. Thank you so much, and also thank you to Judith, who has responded the question in the chat box because we have now enough time.
Take the picture. Take the picture. What you see?
Oh yeah. Before we close this session, maybe Dr. Sindy will take a photo.
I will lead the photo session. Please turn on your camera. Udah dok, nah ada. Ya. Siap. 1, 2, 3. Okay, the next slide. 1, 2, 3. The last slide.
Bisa dimulai lagi, Dokter Sindy. Banyak yang baru muncul.
Oh, oke.
Ya.
Oke.
Sebab ini kan Jogja kan banyak tuh. kolaborasi dengan Jogja.
Ada Dokter Yudi, tadi belum sempat di ada Dokter Edi ternyata, sorry baru lihat. Ya.
Okay, everyone smile. Okay, thank you.
Ya, thank you Dr. Sindy. I think that's all. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon.
Waalaikumsalam warahmatullahi
Mohon
wabarakatuh.
maaf, ini tidak bisa semuanya di-mention. Ternyata waktunya sangat sempit. Ke depan, mudah-mudahan dari UKK akan menginisiasi kembali pertemuan ini menjadi yang lebih luas dan mungkin mengundang pendapat dari semua center ya, dan juga bisa kita berikan referensi-referensi terbaru untuk dicermati bersama-sama sehingga pada saat ada pertemuan semuanya bisa memberikan mungkin pendapat, saran, komentar, dimulai tadi ya dari definisi demam, neutropenia, dan seterusnya sampai pemilihan terapi. Terima kasih untuk kebersamaannya. Mudah-mudahan kita bisa meningkatkan pelayanan kita terhadap pasien. Ini masih baik, tantangannya masih sangat tinggi ya, Dokter Bambang, Dokter Edi, ini banyak expert-expert di sini. Terima kasih, mohon maaf bila ada yang kurang berkenan. Dokter Djatnika nanti ke depan mungkin harus ada sesi khusus. Ini sebenarnya trigger saja, Dokter Djatnika, karena kita tidak punya cukup banyak waktu dan juga barangkali teman-teman sendiri harus meluangkan waktu khusus barangkali. Nanti mungkin UKK yang akan mengawal hal ini. Termasuk ini saya tadi cari-cari apakah ada Dokter Edot gitu ya. Gitu. Terima kasih Dokter Djatnika, Dokter Andi,
sama-sama.
Ida, Dokter Riyadi, dan juga Dokter Bambang, Dokter Sandra, juga tim kami dari Rumah Sakit Hasan Sadikin, ya, yaitu Dokter Nur Suryawan, Dokter Nur Melani Sari, dan Dokter Sindy, juga khusus untuk Dokter Lieke, Dokter Judith, dan di sini ada Britney juga ya. Terima kasih untuk kesempatan kita berdiskusi saat ini. Ya.